Dr. Modi, you can start, sir.
Sir, thank you, sir. Good evening, everyone. And at the outset, I must welcome our esteemed guest faculty from states, Dr. Nicole, and another international faculty, Dr. Sangeeta Sharma, and which have been well coordinated by our dearest EV friend, Dr. Sushant Mane. I welcome our chairperson, Dr. Sanjeev Singh Rawat, sir, and all my esteemed EB members and dearest delegates pan-India. So to start with, may we all have the welcoming address from our chairman, sir, Dr. Rawat. Sir, please.
Thank you, Dr. Modi. Good evening, all. Respected honorable EB members of IAP NRC, the guest speaker, Dr. Nicole, Dr. Sangeeta Sharma, Dr. Sushant Mane, the coordinator for this program, and all my EAP members and dear friends who have been logged today evening on this very important CME on World TB Day. As we all know, World TB Day is observed every year on 24th of March. And this is the day on which in 1882, Robert Koch discovered TB bacilli. And to honor that that very important discovery, we observe this World TB Day on 24th March of every year. The theme for this particular year is, yes, we can end TB, commit, invest, and deliver. Now, this is a very important statement which has been given. India has been doing fairly well as regards TB is concerned. As you all know, India is signatory to the World United Nations World SDG, where one of the component is that end TB by 2030. Now, India in 2018, under the leadership of Honorable Prime Minister Dr. Mr. Narendra Modi, had made very ambitious claim of ending TB by 2025, at least 5 years before the deadline of 2030. And I think we are doing fairly well. The current information by WHO this year indicate that the incidence of TB in India has fallen down by 17%. That is a very important gain which India has done. Apart from that, it has started and 100 days TB elimination program, which was launched by Honorable Health Minister Mr. Nadda in December 2024, in which the emphasis now is to eliminate TB in next 100 days. Emphasis is not to detect cases more effectively, treat them and this menace. So I think we are doing very well as regards India is concerned. But things are not very well at the level of world, because recently WHO Director General Dr. Tedros, he told that whatever gains have been made by the world in TB in last 20 years are going to wiped off because of the huge cut in funding for the WHO. As US is one of the main funding agency, and US under the leadership of Donald Trump, sir, he has led to a lot of cuts in funding of UN. And Dr. Tedros is telling that probably what are the gains we have made in the last 20 years, they're going to be wiped off. But again, Dr. Tedros is hopeful. He has pledged that he would find some solution and he'll find some way out to deal with this problem. So this is all about India and world. IAP NRC, IAP National Respiratory Chapter is very clear to deliver cutting edge technology and very important information regarding all topics, whether they are TB or anything, and what are the recent and latest. In that particular series, on this particular day, we have come out with this TB CME, where we have got international speaker in the name of Dr. Nicole Salazar and Indian speaker Dr. Sangeeta Sharma, who will update us, guide us regarding TB, the current scene. So, without going into much time, I'll request Dr. Narendra Modi, Dr. Narendra Modi, who is our Secretary General, to please introduce our speaker and set the ball rolling. Thank you very much. Please unmute, please. Please.
Thank you, Chairman, sir. And before I go on to introduce our esteemed guest speakers, may we take the opportunity to welcome our immediate past president, Dr. N.K. Kalapanavar, sir, and esteemed speaker, Dr. Sangeeta Sharma. Welcome, ma'am. Sir, welcome.
Thank you.
So we'll start with our first speaker, Dr. Nicole Salajo. So she has a huge list of achievement, and can I have a slide?
Make it full screen,
Yeah.
please.
Is the screen visible?
Yes, please.
Yeah. So she is a doctor of medicine from Harvard's Medical School, Boston, Massachusetts, Pediatric Infectious Disease Fellowship, and Masters in Health Sciences, Department of Epidemiology, Johns Hopkins School of Public Health. Now she is an assistant professor in pediatrics, Division of Pediatric Infectious Diseases, Johns Hopkins University, States, pediatric TV consultant and trainer for the Northeast Regional Training and Medical Consultation Institute, Rutgers, Maryland Department of Health Pediatric TV consultant, and she is also a member of International Union Against Tuberculosis and Lung Disease. Lot many awards to her name. 2020, the Stephen Lawn TV HIV Research Leadership Prize. 2016, Jeffrey Richardson Fellowship Award, Harvard Medical School. And 2014, HIV Prevention Trials Network Scholar Award. She is also a principal investigator for Smart for TB, Smile TB, Prism Kids, and Dolphin Kids, UNIT AID. She has numerous publications and international index journals. So may we have Dr. Nicole Salager for the inaugural discussion.
Thank you for that kind introduction and for having me here today. Okay, I think that should be the right view, but someone can let me know if it's not. So I wanted to talk today about innovations in pediatric TB treatment and prevention, and really what's coming down the road, and for numerous sort of populations. And so I think people in this group know pediatric TB is important. It's a top 10 cause of child mortality when you consider its contribution to malnutrition, pneumonia, meningitis, etc. And over 1 million children develop TB each year, and nearly 250,000 children die of TB each year. The majority of these deaths are in children who don't access treatment. So once we diagnose and start to treat TB, children do relatively well. But just because the majority of children survive TB treatment doesn't mean that there isn't room for improvement. And so a lot of what I'll talk about are shorter treatments, more palatable, more child-friendly treatments for TB that can improve adherence and completion, that have improved safety, and potentially can be cost-effective for programs. And so I'll start by talking about TB treatment, and then we'll move on to TB prevention. So this is sort of the trial landscape internationally, and particularly from a U.S. government-funded perspective. And right now that largely focuses on looking at new treatments that have been identified in adults and shorter treatments that have been identified for adult TB and evaluating them in children. And this is study 31, or ACTG 5349. It's the rifapentine MOXIE study that showed that the HPMZ was non-inferior to the standard RHZE. And this is sort of 4 months it was a 4-month regimen, 2 months of HPZM and an additional 2 months of HPM as sort of the continuation phase. It was generally also considered fairly safe. There was one participant who had some palpitations and a borderline prolonged QT, but generally the moxifloxacin was well tolerated from both a musculoskeletal and a cardiac perspective. There were equal numbers of sort of liver toxicity associated with Hy's law, although a little bit more elevation in liver's enzymes in adults and adolescents taking HPMZ versus HRZE. And this is an attractive regimen for kids because it is shorter. It's already 4 months, but we don't have dosing and safety in children. We do have formulations. There are child-friendly formulations of all 4 drugs, but not fixed dose combinations. Unfortunately, the regimen hasn't been evaluated in any population of any age of extrapulmonary TB. And there's uncertainty about its safety in people living with HIV with very low CD4 counts because they weren't included in the original study. And then there are a lot of concerns about fluoroquinolone resistance, both for TB and for other bacterial diseases. Radiant Kids, or TBTC study 39, is led by Annika Hessling and others, which is designed as a multi-site, open-label, single-arm PK study looking for dosing and safety of HPZM in children, similarly conducted over a 17-week treatment period, and in children less than 14 years old across the disease spectrum. They plan to evaluate 60 participants in order to have 54 who are evaluable in a parallel study that enrolls kids under 2 and kids 2 to less than 14 years of age simultaneously, with both intensive and sparse PK. Safety-wise, they would do ECG monitoring prior to initiating all kids on treatment, as well as other safety monitoring, and particularly LFT evaluation throughout the course of treatment. This will happen alongside some really nice qualitative work, which will understand sort of acceptability and preferences, as well as some costing work. And this will happen both in the United States and internationally. I will say that this study is on hold just because of funding issues within TBTC. So it has been delayed a couple of years. So it won't be available immediately. But alternative sources of funding or co-funding are also being looked at. This is a study that is near and dear to my heart. It is the study mentioned at the beginning that I am the PI of. And this is sort of a large multi-center open label randomized controlled treatment shortening non-inferiority trial that's happening, well, that was meant to happen in 6 countries, including India, with sites in Chennai as well as Pune, in children less than 10 years of age with drug susceptible TB. And we were going to compare 8 weeks of the HPZM regimen against 16 to 24 weeks of HRZE. And this was really meant to be whatever the standard of care was in the country that we were doing the evaluation in. So in many of the African countries, the SHINE sort of WHO recommendation has already been implemented. In countries like India, where that isn't quite the case yet, there would not be stratification and everyone would have received 24 weeks. I say would have because this study was funded by USAID. And so we received a termination notice 2 weeks ago, although we are actively searching for new funding and hope to restart the study soon. We had actually started enrolling participants in one of our sites in Uganda before we were terminated. The 8 weeks of HPZM comes from a variety of sort of data. And so here, the sort of idea was if adults need 6 months of HRZE and most children do well with 4 months of HRZE, can we further shorten the HPZM regimen from 4 months? And how low can we go? And so we went back to a lot of the mouse data that are done, and the references are sort of here at the bottom. And we looked at a number of different mouse models. And in the high-dose aerosol model, you get similar outcomes between 8 weeks of PMZ, no isoniazid, as with 16 weeks of RHZ, no ethambutol, but thinking about what may be the most active components of each of those regimens. In the lower burden chronic infection model, there were similar relapse rates between HPZE, so ethambutol, not moxifloxacin, and 4 months of HRZE. So thinking that even without the moxifloxacin, you have an equal number of mice succeeding. And in adults, the HPZM was more effective than the HPZE regimen. And then finally, looking at the paucibacillary model of TB in mice, 4 months of RH was as good as 2 months of HP. And I think together, we felt that these mouse models would predict that 2 months of the HPZM regimen would work as well as the standard HRZE regimen in paucibacillary pediatric disease, assuming similar rifapentine exposures in children as in adults. And here for paucibacillary disease, what we had decided to do, instead of making sort of a complicated stratification algorithm that includes both evaluation with chest x-ray and with sputum smear and culture, to actually just use the sort of notion that children less than 10 years of age have more paucibacillary disease, and that adolescents 10 years and older are the majority of children who have longer or sort of less paucibacillary and larger or more disease. And so through that, the majority of children would do well with 8 weeks, and clinicians are always able to extend when needed. And so that was the trial landscape for drug-sensitive TB. Unfortunately, from that perspective, HPZM is on hold for one study and canceled in another, but actively looking for funding, and so hoping that both of those studies are initiated soon. I wanted to talk a minute about drug-resistant TB, and specifically looking at the BPAL-M and BDLL regimens. And so, as many who treat drug-resistant TB know, TB Practical evaluated the BPAL-M regimen against the standard of care, and that trial was stopped early because of fewer unfavorable outcomes with BPAL-M versus the standard of care, fewer treatment discontinuations and death. There were some heterogeneity in some of the subgroups, and particularly those with living with HIV, with fluoroquinolone resistance, and a little bit by geography. But in this study, pratominid in particular has really only been studied in adolescents 14 years and older. And this is largely because of some preclinical work that showed sperm toxicity in some animal models. And so here, pratominid is thought to potentially cause testicular atrophy and impaired fertility in male rats. And there was a sperm toxicity study done in men receiving the BPAL-M regimen in South Africa that was reported at CROI last year, which did not show any negative effects in the reproduction function in adult males, looking largely at sort of number and morphology of those cells. And so here the idea is that for children, this would be a 6-month duration across the age and disease severity spectrum. Pratominid PK and safety is being evaluated in Impact 2034. Because of the sperm toxicity, it is only being evaluated as a single dose of pratominid added to an optimized background regimen in children, and really in female children with rifampicin-resistant tuberculosis. And you can see the dosing sort of here on the side. There are nice scored 10 and 50 milligram dispersible tablets that are easier for children to swallow, that are being used and developed. And the plan is to evaluate somewhere between 36 to 72 children less than 18 years of age with or without HIV. This study started enrolling in October of 2023. My colleagues Ethel Well, Tony Garcia-Prats, and Pauline Howell are the co-chairs, and they've had really nice enrollment to date. I do believe there's one Indian site within the Impact Network that's participating in Pune, though they may still be waiting for some regulatory approvals before starting. I wanted to spend a moment talking about BTB and the BDLL regimen. This study evaluated the BDLL regimen in children 6 years and older, along with adults and pregnant women with RIP-resistant TB. They studied a sort of strategy of starting with BDLLC and then moving to BDLL or BDLC, depending on fluoroquinolone susceptibility. And at the interim analysis with 199 people, there was no major difference between the efficacy of the BDLLC strategy and the standard of care. Really had comparable efficacy and safety, and felt this was a good alternative to the BPAL-M regimen, and particularly for special populations like children and pregnant women where Protomanid has not yet been studied. Similar outcomes to the Beat TB India study that showed 91% successful outcome with the BDLC regimen. And so this is now approved by the WHO, and really because there's dosing of all drugs from 3 kilos and sort of birth upward, it's a potential option for a short course treatment and 6 months of treatment in children of all ages. To optimize the PK and safety of some of the drugs, Impact 2020 is also a phase 1/2 PK study that will evaluate dosing of really all 4 of the drugs to really maximize and ensure that the doses we have for children match the exposures that we see in adults, which unfortunately for several of these drugs has not yet been shown. We have nice pharmacokinetic models of dosing that can be improved, but has not yet been studied for safety in these populations. And so Impact 2020 will hopefully be initiated sometime in the next year or so, and we'll look at dosing and safety of the BDLL regimen in children less than 15 years of age, and we'll have cohorts of children with and without fluoroquinolone resistance, and we'll enroll just about 100 children. I think this is also nice because they plan to have to study this with just an 8-week duration of linezolid to really try to spare a lot of the linezolid toxicity we see with longer durations. Dr. Sushant Mane will remember this study, and this was also USAID funded and has also been terminated in the last 2 weeks. We had planned to enroll many children from JJ Hospital and from a site we were working on with him and NERT there. But here, the idea was to study shortened regimens of the BDLL regimen, similar to sort of the SHINE study, but for drug-resistant TB and evaluating BDLL. And here we would take children less than 14 years of age with fluoroquinolone susceptible RIF-resistant TB, and somewhere upwards of 120 up to 200 participants, and either randomize them to the BDLL regimen or the WHO recommended control, which could be BDLL or could be a 9 to 18 month all oral regimen. And For those in the intervention group who are getting BDLL, we would then stratify based on disease. So if they had less extensive disease, they would receive 4 months of BDLL. And if they had more extensive disease, they would receive 6 to 9 months of BDLL, depending on what was, clinically appropriate in the patient's course. And I think the idea here, again, stemmed from mouse model data that showed 4 months of BDLL could be as good as 6 months of HRZE, albeit in mice with drug-sensitive TB, but really felt that at least for children with paucibacillary disease, as defined by SHINE and the current WHO criteria, that we could do a little bit less. So I'm going to speed up and just talk about TB prevention and some new innovations there. So 3HP, 3 months of weekly rifapentine and INH. We now have a child-friendly formulation available since last year, and dosing for children from birth, 3 kilograms and above from TBTC study 35. Unfortunately, because of varying ratios of rifapentine and isoniazid across the age spectrum, it may be challenging to have a fixed dose combination that works for all children. So it's not clear whether or not that eventual and desired FDC will be possible, with at least with the data and the dosing that we currently have. There was a study that has recently been completed and whose data will hopefully be shared in the coming months, called Rifapentine Crush, which will look at the bioavailability of the adult FDCs as crushed, so not a child-friendly formulation, but at least in a form that can be given to children. And for children 15 kilos and above, the WHO is already recommending that because the ratio there is sort of 1-to-1 and can be used to treat those children. Dolphin Kids was also mentioned at the beginning. I'm the PI of that study, and in this study, we're looking at 3HP in children living with HIV. And here, what we know is that children have lower dolutegravir exposures than adults, even at recommended dosing. And so results of the original Dolphin study that showed 3HP could be given to adults living with HIV without a dose adjustment could not be extrapolated to children. And so Dolphin Kids is a single-arm phase 1/2 PK and safety study to assess the drug-drug interaction between dolutegravir and 3HP in children living with HIV less than 18 years of age with suppressed viral load who have a TPT indication. The study is happening entirely in South Africa. And we started by evaluating 3HP with twice daily dolutegravir just to keep kiddos safe. This was reported at the union meeting in Bali last year. And when we did based on those data, we sort of re-simulated what children's exposures of dolutegravir would look like with once daily dolutegravir. And you can kind of see here from the graph that this 300 nanogram per ml level was reached in the majority of children, and which is really the exposure, the lower end of the exposure seen in adults taking a 10 milligram dose of dolutegravir, which was shown in the spring trials to be as effective as the 50 milligram dose of dolutegravir. And so from that, we decided to evaluate 3HP with once daily dolutegravir and have completed our enrollment and are sending all of our PK to the lab on Monday, and we're hoping to have results possibly by IAS, but more likely by the union to report on the safety and efficacy of 3HP with a once daily dolutegravir. The Impact Network is also evaluating the 1HP regimen in children, and Christy Beniri and I are the PIs of that study. And so this is a phase 1/2 multi-site open label non-comparative dose finding study in children less than 13 years of age with or without HIV with an indication for TPT. We will also be studying the drug-drug interaction with dolutegravir in a sample of 30 children with HIV, and then also just dosing in general, with 60 household contacts without HIV. We are hoping to begin this study later this year in about August or September, and hoping to have results about 2 years later. Asteroid is a study by TBTC, which is looking at 6 weeks of daily rifapentine in the absence of isoniazid. And here they plan to enroll about 3,500 people looking for efficacy, and about 1,100, and then safety will be evaluated in all those folks too. And what's nice about this is Kelly Dooley, who's the PI of the study, received an NIH merit grant to really be able to simultaneously evaluate the dosing and PK in both children and pregnant women, so that they can confirm their model-based dosing and enroll 30 children in a semi-intensive PK study. And then once they do that, they'll be able to open enrollment to children in this study, which can further generate safety and effectiveness data in this population, which is great. It's nice to see early inclusion of children in results, so we don't have delayed availability of these regimens as we have in 3HP and in 1HP. This is a third study that unfortunately also was included in the Smart for TB USAID sort of funding that has also been terminated in the last couple of weeks. But what's sort of exciting about this is that we were going to study 1 month of bedaquiline for pan-TB prevention, and have nested PK studies for children and pregnant women, and then evaluate this in a large phase 3 study, with the idea that there will simultaneously be folks working on a long-acting form of bedaquiline, and that this could represent the possibility of a one-shot, no oral medication TB prevention regimen for all populations, and for all folks who are at least have bedaquiline sensitive TB, so across the DS and DR TB regimen. And again, Eric Nurberger and Sonia Krishnan, who are the PIs of the study, are looking for alternative funding to move this forward. I wanted to just very briefly talk about care delivery models. It's part of the new guidelines from a WHO perspective. And as wonderful as short and well-tolerated TPT regimens are in children, we also have to be able to find the children to get them on treatment to protect them. And so I talk about this whenever I'm talking about TPT. The ACT-4 study really evaluated clinic level quality improvement and aimed to improve the number of household contacts identified and initiated on TPT. And while successful, I think the majority of household contacts still did not engage in care. And I think it's just hard to get well people who are otherwise busy to often present to care. And so the Prevent TB study sort of came next, and there they used community health workers to identify and refer children to the clinic for care, along with adherence support during TPT. And children were 35% more likely to complete treatment if they had a community health worker who was going to the household and facilitating a clinic visit and adherence while on TPT. The CONTACT study was a cluster randomized trial of community-based contact management that was done as part of the CAP-TB study funded by UnitAid. And here TPT was initiated by a nurse in the home in Cameroon and Uganda. And they found a 3 times increased odds of initiating and completing TPT in the home-based versus facility-based arm. It was also acceptable, considered family-centered, and cost-effective. Also UnitAid funding, we conducted the CHIP-TB trial in Ethiopia, and we used community health workers, fairly well-trained community health workers who were already initiating sort of malaria treatment, diagnosing and treating neonatal sepsis, and following children who were malnourished. and providing vaccines for children. So a little bit more than your standard community health worker. But these folks were able to safely evaluate and manage TPT in the home when task shared with the TB focal person based in the clinic in rural and semi-urban areas of Ethiopia, just outside Addis Ababa. This was also considered acceptable, family-centered. It was cost-saving for the family and low cost for the health system, and was really a nice alternative in the Ethiopian setting for initiating TPT in the household. And so I think when considering community-based care models, I'm a huge proponent of them in general, but they need to be appropriate for the local setting. Consider the training of the local healthcare workers, what's acceptable from a community perspective, from a healthcare perspective. They need to consider staff availability. Training and communications are just key parts of the project. And then developing and introducing the appropriate supportive M&E tools the importance of that just cannot be understated. And so when considering TPT and what people should give, I've talked a lot through our Unitaid work and other work about 3HP versus 3RH. I think 3RH was a great opportunity and a great regimen for children and for programs, because it is the continuation phase of TB treatment. There are fixed dose combinations that are dispersible, but it does need to be taken daily. And there are significant drug-drug interactions with ARVs and with other drugs. And so I think that the fact that 3HP now exists and has dosing for all ages and dispersible formulations, albeit not in FDC, with fewer drug-drug interactions, hopefully, this is really a shorter regimen, can have better adherence, and particularly on a weekly basis, and is in general found to be cost effective when compared to 6 or 9H. And so really a much better option in thinking through what is most appropriate moving forward. And then just a reminder that there are lots of new things that I talked about that are coming forward, and I think being nimble and being able to adapt to new scientific advancements as more and more options become available will also be important. I will leave it there, and I'm happy to take any questions if there are any.
Thank you, Dr. Nicole, to have this wonderful presentation and bringing in all the new drugs and regimens and latest research findings and recommendation to TB treatment. And we will take up the questions afterwards, after this second presentation of Dr. Sangeeta Sharma.
I think he has to leave.
Okay,
So,
okay.
You have to leave for clinical rounds. What we can do is, probably if there are any questions, then we can mail it to you, and then you can mail us back the answer so that we can circulate to our attendees. Is that fine, Nicole?
And I'll be on for a little while too. So if people put things in the chat, I'm happy to answer them there too.
Okay.
Yes, Dr. Nicole, thank you for an excellent talk. Now that the basic you have told us regarding various new regimens are going to come and research is going on. But WHO in 2022 has recommended short regimens for drug-sensitive TB, like 4 months, according to SHINE trial, and even in conclusion. So what is why these regimens are not being taken up in the developing world? Why still, like for example, in India, we still don't take up this regimen? Why across the world, why these regimens are not being taken up, and still you are treating TB for 6 months or 9 months? So what is the reason why these short regimens are not being taken up as well as they should be? Because WHO has recommended them in 2022. So any idea what is the reason?
Yeah, no, I think there are a lot of reasons why various settings are or are not taking up the regimen. I think, change is always hard. And shortening treatment for, I think, most clinicians takes a little bit of comfort, right? And trying it out in a few patients, seeing if it works, and then gaining more and more clinical experience and feeling comfortable with it. So I think that's part of it. It's not all of it. I think the other piece is some of the, and what other settings have, who have started sort of smaller trials and things are starting to really do is really think through the challenges in interpreting chest X-rays and in getting sort of the samples and smears and experts that are required to kind of make that decision as to whether or not someone is a severe or non-severe has severe or non-severe disease and requires 6 or 4 months of treatment. And it seems maybe easy when you say it out loud, but when you're really in a clinic with a clinician trying to get all of that done, it's not the easiest thing to do. And there are a lot of questions about what if this, what if that, what about this X-ray finding, or what if what if this clinician in this area doesn't have the training to read chest X-rays, or what happens if we don't have the tools or the skills to obtain the gastric aspirate or do the induced sputum. And so I think there's a lot left to work out. And that's part of the reason why in the SMILE trial, we were really trying to simplify that stratification and try to say, okay, let's look at it by age and then by clinical status. So if they haven't improved well enough by the 4 or 8 week mark of treatment, we extend it to the full 4 months. But for the kids who do show sort of a quick resolution of symptoms and really have and really do well, can we get away with 8 weeks? And I think some of that is a little bit easier, and particularly in areas where it's not so easy to have chest X-rays read or done, I suppose, and then also to have gastric aspirate performed in sort of decentralized clinics and not requiring kids to travel to far district hospitals. And I'm a little bit less familiar with the Indian setting. I've spent a lot of my time in the last 15 or 20 years working in sub-Saharan Africa, but I'm going to guess that to some degree the challenges are also quite similar.
Thank you.
Thank you. Can we take a few more questions?
Yes, please.
Yeah. Dr. N.K. Subramaniam sir has asked, can we go for shorter regimens in India?
That she's already answered.
That is answered.
Yeah.
And evidence in clinical settings favoring breach. Dr. Nicole ma'am.
Oh, is this for bedaquiline? I think I didn't say this, but I think the 1 month of bedaquiline and the duration is dependent on this paucibacillary mouse model, where 1 month of bedaquiline worked just as well as 1 HP, as 3 HP, as 9 months of isoniazid. And that actual mouse model has actually been quite accurate in sort of predicting 3 HP and 1 HP. And so we're hoping that it's also predictive of 1 month of bedaquiline. I think, there are concerns around, the development of bedaquiline resistance and what that means and what it means to have a tail for such a long time. As you know, bedaquiline stays in the system for quite a number of weeks to months. And so lots of questions that we're hoping to be answered in that trial. It's attractive, but it also, there are some very legitimate good questions about whether or not it should be done.
And Dr. Nicole ma'am, your opinion on community level TPT to all, irrespective of TST or chest X-ray in highly endemic areas?
Yeah, no, it's a really good question. And I think every country and every program has its own sort of, and should be making decisions for its population about the safety of TPT in general, for people who may be lower risk and who may not have a positive TST or, and may want to have a chest X-ray before initiating TPT. And I don't think that that's wrong. In Ethiopia, at the time where we did this study, we followed country guidelines. So there, all children less than 15 years of age, irrespective of TST and irrespective of chest X-ray, would receive TPT as long as they had a negative symptom screen. And what we found was that one child developed TB despite not having a chest X-ray before initiating. So one of about 500 children. That child was in the control arm and was initiated on TPT by a nurse and not by a community health worker. And generally, we found it to be pretty safe. I think in my clinical experience in a trial in South Africa, this trial in Ethiopia, and just general clinical experience from days where I was practicing in Eswatini, you know, I think doing a symptom screen when you follow up monthly while someone's on TST is important. I think you can miss very subtle and early TB. I think you can also miss asymptomatic hilar adenopathy, which is considered TB disease when you don't do a chest X-ray. But in general, these kids who are asymptomatic or minimally symptomatic are really folks who have very paucibacillary disease. So if you start TPT, the likelihood of developing resistance is just highly unlikely. And even if kids have full-fledged disease, it's also unlikely, because when you kind of do the math and like how many bacilli are in a chest in the chest of someone with TB versus the amount of TB that needs to be sort of replicating in order for resistance to develop, is many, many fewer in a child than it is in an adult. So I feel very comfortable initiating TPT and following children and stopping should they become symptomatic. And in my experience, those kids don't develop resistance, respond very well to first-line TB treatment, and it isn't so much an issue. As long as folks are well-trained and are a little more inclusive, right? Remembering the symptom screen is also going to bring you everyone who has a URI or a cough for any reason to the hospital to be evaluated either by a higher level clinician, either a nurse and or physician. And so in my experience, it's worked out very well, but and particularly in children, I would probably be a little I mean, I don't treat adults, I'm a pediatrician, but I'd be more reticent in an adult who had just more higher bacillary loads in their TB in their chest, but in kids, I feel very comfortable.
Thank you, Dr. Nicole. And I think you can leave now, and we'll move on to the next speaker, Dr. Sangeeta Samma.
Thank you very much, Dr. Nicole. It has been excellent.
Thank you, Nicole. I mean, if you allow me, I can answer those questions for Nicole in Indian context, because being in the in the National Task Force, the question is directly related to why these regimens, they've not been implemented in our country. For WHO, even I'm part of those guidelines. WHO does a grade assessment, and that may not be truly applicable to our own problems, because we have peculiar problems in our country regarding the implementation of those trials. So regarding the BD-LLC, ICMR is funding a trial at my site in which we have already finished the recruitment of 219 children. And we are comparing the two longer regimens with the shorter bedaquiline and delamanid combined regimen. This is funded and sponsored by the ICMR. So because ICMR and our country won't literally accept the data, because our country needs in-house validation for the DCGI to give approvals. So that is one of the reasons. And regarding the SHINE trial and the shortening of regimens, the questions which are peculiar to that is that, in SHINE's trial, there were deaths. So during our meeting, I asked the ICMR team that you need to come out clear that, when you have non-severe TB, there should not be any death. Why were there any deaths? Because we cannot take it, a shorter regimen which causes deaths, and we cannot let it go in our country. And the other thing was in Shine trial, it's written that ethambutol was not used in the continuation phase, while in our country we are using ethambutol in the continuation phase. And the Pune, which was the site, they used ethambutol. So, that was a bit of a contradictory data which emerged out of these trials. That is the precise reason why we are still lagging behind, and we have not implemented these, these regimens in our country. So thank you for giving me this opportunity. And now, without wasting further time, I think we are already running late. It's already 9:49. So, sir, tell me how much time do I have, so I'll adjust my speed accordingly.
Madam, 20 minutes.
Okay, 20 minutes. Okay, sir, fine.
Yeah.
Then 20 minutes would be fine. So, and thank you for giving me this opportunity, to talk about my experiences in. So you can see my presentation?
No, madam.
Yes?
No,
No,
no.
ma'am.
You cannot see my presentation? Sir, I've already shared it. I don't know why.
Ma'am, you can stop and do it again. Sometimes it happens out like that.
Okay, okay, okay. Can you see now?
Yes,
Yeah.
madam, it has come now.
Yes.
Okay, thank you. I'm
Uh,
sorry about that.
Make it full screen, ma'am. Yes, madam. It is full screen now.
Okay, sir. So, I'll be talking about the difficult to treat TB in children. And so my talk is basically directed on case discussions. I'll be limiting to the case discussions. So this was a 14-year-old child who presented, to our institute with a neck swelling and fever for 1 month with poor appetite. There was no past history of ATT, no history of contact. And on local examination, there was a cervical lymph node which was enlarged, that was 3 centimeters, and systemic examination was normal. So this was the chest X-ray. We did a sputum. It was saliva-induced sputum was negative, including CB-NAT. MTB was not detected. So the cytology, the child was given a course of antibiotics, and based on those antibiotics, there was no response. And then the FNAC was done, which showed caseation necrosis, and it came out AFB positive, RIF resistance not detected. So based on that, the regimen was obviously, everyone knows it's drug sensitive, that is rifampicin sensitive regimen was started. And because the child's weight, I forgot to tell, that was 42.5 kg. So, whenever we have a weight of child which is more than 39 kg, that is 40 kg and above, we give the adult doses. That is 10 milligram per kilogram of rifampicin and 5 to 8 of INH. So that was precisely what was given to this child. And even after 1 month of starting ATT, the child did not improve. There was no weight gain. Fever, though, had responded, but there was no change in size of the lymph nodes. So now I would like to discuss over here that, what is the usual response which you expect when you start ATT. So it's clinical, radiological, and bacteriological. Clinical is that usually, the symptoms, they start to improve. There is defervescence of fever, cough by the end of 2 to 4 weeks. And usually, there is a weight gain which starts by, say, about a month. But 25% of children may not have any significant weight gain. Now, coming to the radiological findings, because radiology always takes more time to clear, so it can take about 1 to 2 months, before you have response, and sometimes there's even a poor correlation between the usual response, as there may be appearance of new lesions due to TB iris. And but most important and significant is the bacteriological conversion, which usually occurs within 1 to 2 months. So, but whenever there is delayed response or persistence or reappearance of these symptoms, that is the time usually, we always should make one suspicious that we we need to work on further. So, what are the usual causes when you have a poor or non-response? Most important is wrong diagnosis, and this is particularly important when you're dealing with a clinically diagnosed tuberculosis. In this case, it was microbiologically confirmed, but majority of children, you may not have microbiological confirmation. So we are dealing with a clinically diagnosed case, and always there is always keep it in mind that the first question, that whether it is TB, because it may as well be non-TB. And then you have various confounders and mimickers on chest X-ray. And even always look at the DST report, whether it's from a reliable accredited lab, and keep in mind MOT, especially when you're dealing with situations of immunocompromise like HIV or other, primary immunodeficiencies. Then presence of comorbidities like HIV, diabetes. Then the other thing which is important is wrong doses, wrong drugs. And also, like in this case, because microbiologically confirmed, so the top wrong diagnosis does not there. It could be HIV, diabetes, or presence of comorbidities, wrong drugs, dosages. We again need to recheck. Then most important is poor compliance. I have had children where parents are so particular that they giving the drugs to the child. But remember, there is always a slip between the cup and the lip. Always make the child swallow the drugs in front of you. And there is what is the last thing, that is drug resistant tuberculosis or a paradoxical response. Paradoxical response is when the body's immunity improves as you start ATT, or a child with HIV when started ART, the body's response improves. Then the body, there is appearance of new lesions, as we have heard about TB, iris, similar to what we are familiar with HIV. So keep this in mind. So this is the algorithm which we normally follow. Whenever there is a child who is failing on the first line treatment, that is experiencing clinical and or radiological deterioration, most important is always send the specimen for the test. Which test? That is NAT. It could be CBNAT or TrueNAT, which is indigenous, then smear. And if smear comes positive, then immediately get the first and second line LPA. First line LPA tells you about rifampicin and INH resistance. Second line about FQ and SLI, although we are not using SLI. And the other thing, always send for MGIT. So this is the system which is all in place in the NTP already. So you don't, if you're going towards the public setup, automatically the sample is divided into two parts. NAT is done at site, and the other part of the specimen or the second specimen automatically goes to the intermediate reference lab, where they do the smear, followed by, if it is positive, first, second line LPA, and if it is negative, with the liquid culture. So if it is sensitive, obviously you give sensitive treatment, but if it is, then you have to even restart the sensitive treatment if there is no response. And in case there is drug-resistant tuberculosis, then obviously you'll be giving the DRTB treatment. But in case you are unable to fish out the organism, that is DST and DRT, the MTB is not detected. Always keep it in mind that it could be non-TB, or there could be a paradoxical upgrading response, as I already discussed. But if you are sure that it is TB, and it is not paradoxical upgrading response, then fair enough to start MDR TB treatment. That is what you call as the probable MDR, And like in this child, after 1 month of starting ATT, doses was rechecked. They were appropriate for weight. Compliance was good. All routine came out normal. Sputum was negative. FNAC repeated again. There was caseation necrosis, and CBNAT showed MTB detected. And MGIT came out that it was R, H, and FQ sensitive case. So, the differential diagnosis is that it was not diabetes, HIV. There was no super added infection. We had checked the drug dosages. The compliance was good. It was not MDR TB. So these are the two things which are left. That is maybe the drug levels, that is the PK, that is the TDM, that is the blood levels of the bioavailability of the drugs is not proper, that is lower, or it could still be per. So we did the TDM, and TDM came out low for rifampicin. So rifampicin levels, they were found to be below the therapeutic range. So RSZE was restarted with increased dose of rifampicin. And again, the TDM was done after 3 weeks. The patient had started to improve. There was no fever. The appetite had improved. There was weight gain. And now, after 3 weeks, that on increased dosages, um, the rifampicin blood levels came out to be within the normal range. Because we were giving higher rifampicin levels, remember, we have to also do LFT to be monitored while on increased dose of rifampicin. Normally, we do not advise that you do routine LFT, but in such situations, you may have to do a LFT. So now coming to the second case. Now this is another interesting case. This child presented, to a private setup with a history of fever, headache, vomiting for 1 month, and vomiting and cough for 15 days. With these complaints, the child was first taken to a private hospital where the child was investigated for fever. LP was done, started on IV antibiotics, given cough syrups, bronchodilators, but there was no relief. So this was the chest X-ray. The chest X-ray, the CBNAT, sorry. So the CBNAT came negative. The lumbar puncture showed that, there were lymphocytes and proteins were raised, and MTB was detected was very low with RIF resistance detected. They did a contrast enhanced MRI which showed meningeal enhancement, as you can see, and there was small nodular foci on the cerebellar hemispheres and both interior temporal lobes. So with this report, the child was referred to us in lieu of the CSF and the the gastric aspirate report. Uh, the symptoms of fever, headache, vomiting, they were persisting. Although the past history was not significant, development history was also there was not significant. The child was good at studies. Family history, there was no history of contact with tuberculosis. On journal examination, except for CNS, neck rigidity, rest everything was normal. So we did the investigations. Investigations also essentially came out normal. This is the chest X-ray, which you can see there is a patch on the right side. And the CBNAT, the sputum CBNAT MTB was detected. And this time in the sputum CBNAT, the RIF resistance came out indeterminate. So with this, I would like to discuss about how do we interpret the CBNAT reports, because this is a very important, very frequent question which, we clinicians face. So the most important is then when the MTB is detected, then there is no problem. We treat, and the problem comes when the MTB detected very low and RIF resistance is detected, then what to do? And the other situation, MTB detected RIF resistance indeterminate. Like happened in this case, the CSF showed that MTB detected very low. So the guideline is that, you have to start the DSTB treatment in a new case with no risk factors. As this child had no risk factors, there was no family history of contact. There was a child was seronegative, blood sugar was normal. So in such situations, so what to do now? If RIF resistance is detected and MTB detected very low, so you in a new case with no risk factors, so the most important thing is that we have to start the DSTB treatment, and you have to send the retest. Now, if the retest also, again, MTB detected, but now it is RIF resistance, then you treat as DRTB. But in the second lot, if MTB detected very low, RIF resistant not detected, then it is, you have to continue with your DSTB treatment. But if it is indeterminate, again, continue with DSTB treatment. Now coming to the RIF resistance indeterminate. In such a situation, again, you have to start DSTB treatment, send for the retest. Now, if again on retest it comes RIF resistance indeterminate, continue to treat on the DSTB treatment. But if RIF resistance is detected, then it is you have to switch over to the DRTB treatment. And obviously, if MTB is not detected, then you continue with your DSTB and you send the culture. Or remember, all these reports, they have to be confirmed by sending the culture followed by the DST. So in this case, as you can see, in lieu of the sputum done at NITRD and the CSF report done outside, the child which showed MTB detected very low with RIF resistance, and the other report showed MTB detected with RIF resistance indeterminate. Both situations warrant that the child to be started on the drug-sensitive regimen along with decongestives and steroids. Despite that, the child did not improve. There was no clinical improvement, fever, cough, fever, headache, they continued. So we did a CT head, just to rule out hydrocephalus and send out the samples again. This time, the CSF showed, again, MTB detected very low and drift resistance detected. And the CBNAT showed MTB detected very low, RIF resistance detected. So as you can see, because the child was not improving despite starting the DSTB treatment, and there are in fact 3 reports which are same. That is MTB detected very low with the RIF resistance. And as I've already said, that whenever the same report is being repeated, even if it is very low, we have to take it as RIF resistance and start the MDR-TB treatment. So the child was shifted on to MDR-TB regimen, all oral longer regimen. As a word about the drugs which penetrate the CSF. This is another very important thing. Remember, just 2 things. Ethambutol has a very poor penetration. Isoniazid, PAS, and injectables, they penetrate the meninges only when there is inflammation. Rest drugs which have got good penetration are the fluoroquinolones, linezolid, cycloserine, ethinomide. In fact, there is a regimen which has been recommended by the WHO, the shorter 6 months regimen for drug-sensitive TBM, in which the ethambutol is replaced by ethinomide. And for us, still, the world is gathering data for bedaquiline and delaminid. So 1 month follow-up in this child on MDR-TB regimen showed that the child was accepting and had started to show signs of improvement. Fever had subsided, headache had also responded. So now this is the second case, and my final case is another very interesting case. Is now this was a 4-year-old child, 12 kg, who was a resident of Delhi and presented with complaints of fever, cough, loss of appetite, and weight for last 3 weeks. There was no history of COX in the past, but the grandfather had died of tuberculosis 6 months back, but no papers were available. But according to the family, the grandfather was on injectables. So probably, the grandfather had drug resistance, although there was no records available. And this was the chest X-ray. Now, based on this chest X-ray and the CBNAT report of the gastric aspirate, which MTB detected low RIF resistance, and the culture report also showed that it had rifampicin and INH low level resistance. That is, INH in high doses can be given, although FQ was sensitive. So the child pre-treatment evaluation was done, and the treatment which was given to this child based on the CBNAT report, the LPA was the child was started on shorter MDR-TB regimen. We all know the shorter MDR-TB regimen, although in our country we are not giving bedaquiline, because bedaquiline for us is still on hold. The DCGI has not given approval for bedaquiline to be used for children less than 5 years and 15 kg. So bedaquiline was replaced with amikacin. And the drugs were given. The 6 months, 4 to 6 months of the intensive phase, and followed by 5 months of the continuation phase, in which high dose INH and ethanamide is stopped. This is, I'm talking of, before linezolid was recommended. Now, linezolid is recommended. You can use 2 months of linezolid instead of ethanamide. That's the new recommendation for shorter MDR-TB regimen. But now, and the child was declared cured. The final outcome was cured. So, after 3 years, now the child now presents to NITRD. So this was the first time I saw this child, and this was the chest X-ray with which the child came to us, with again fever, cough for last 6 months, and pain and tenderness of both legs for last 1 month. Now the present age of the child was 7 years and 20 kg. So now, as you can see, the highlighted reports, these are the reports. Now the child had developed, as the child, it was smear 3+. The first line LPA showed rifampicin and INH both high as well as low level resistance. That means INH is totally knocked out, and fluoroquinolone moxi high dose. As you can see over here on this box, this is 3C mutations. A 3C mutation, that means you cannot give moxifloxacin even in the high dose. And as you can see, these red resistance reports, all levoflox, moxiflox was resistance. So, imagine the fate of the child. Presently, the child has bilateral extensive pre-XDR-TB. So we started the child on all oral longer regimen. So, we have group A, B, and C drugs. So we try to include all the group A drugs, the 3 group A drugs, and try to include both group B drugs. And if we cannot use group A, as in this case, we could not use fluoroquinolone, then after using bedaquiline, linezolid, and 2 group B drugs, clofazimine and cycloserine, then you have to add delaminid. So in this case, calcium was a bit low. So calcium correction, 3 electrolytes whenever you're giving these regimens are potassium, calcium, and magnesium. So, now let's review this case. This was the case in which the grandfather had died with tuberculosis, 6 months back, and was on injectables. So probably MDR. And this was the chest X-ray of this child. Although that time it was only low level INH and rifampicin resistance. So it was rifampicin and INH resistance. But as you will be able to appreciate, it is more than non-sphere TB, more than one lobe involvement. And even you can see some infiltrations even on the left-hand side. So this is where, the clinician that time did wrong. So it was sphere pulmonary TB even at that time, and the child should have been given longer MDR TB regimen at that time rather than giving the shorter MDR TB regimen. So that is precisely the reason why I got this case. All these three cases which I have discussed, they have a lesson to learn, because these are the usual problems which we face in our practice. So the final regimen which we started was obviously bedaquiline, linezolid, that is 2 group A drugs, 2 group B drugs, that is clofazimine, cycloserine, along with delaminate, and the child improved, and finally the child is cured and is on follow-up. Because it is very important, even the program emphasizes that always keep children on follow-up for at least 2 years. So the child has just follow up every 6 months for 2 years, especially patients with on MDR or pre-XDR. So to sum up, I would like to end my talk over here by saying that whenever there is a child who is failing on the first line regimen, that is, there is clinical and or radiological deterioration, always try to send the specimens, because the maximum chance to get the organism is right in the beginning. So send the appropriate specimen, whichever is available, and send for NAT. As we discussed, NAT is done right initially, and the second part of the specimen or the second specimen automatically goes to the higher lab, where the smear, depending upon the smear result, if it is positive, you do directly a first line LPA that tells you about rifampicin and INH resistance. Second line LPA tells you about the FQ resistance. But if it is negative, automatically the sample is put up on liquid culture, MGIT, followed by DST. And always get HIV and blood sugar done. And if if it turns out to be DSTB, then you have to restart the DSTB regimen. Don't continue the DSTB regimen. You have to restart the DSTB regimen. Now on DSTB regimen, if the child is not improving, that is, there is poor response, then always keep in mind, and response is judged after 1 month. So by 1 month, we expect some improvement, but if the child is not improving, then it could be presumptive DRTB. And again, you have to send the samples once again. But now, if you get the DRTB report, then you start the DRTB regimen. But this is the ideal situation. In majority of the children, a majority of our children, they have possibly disease, sample collection is difficult. So for us, majority of times DS or DR cannot be determined. So always keep in mind that you have to review your diagnosis. It could be non-TB, it could be a paradoxical upgrading response, or probable drug-resistant tuberculosis. In that case, take detailed history of any death in the family, close DRTB contact, and treat as per the DSTB of the contact. So, we have these regimens currently which are available in our country. Just to sum up, this is the total overview of our program. So whenever we have a new or previously treated drug-sensitive TB case, by drug-sensitive, we mean that is rifampicin and INH sensitive, then you have to give 2 RSZE and 4 RHE. If you have INH resistance, Then there is a separate regimen, that is uniphasic regimen, 6 to 9 months of rifampicin. You don't give INH, you give ethambutol and pyrazinamide and add a fluoroquinolone, that is levoflox or moxiflox, depending upon the resistance pattern. And if it is severe disease, that is severe pulmonary tuberculosis, then you can extend it for 9 to even 12 months. Now, coming to the non-severe kind of, how do we judge the severity in case of children? The severity criteria, they're different from adults. For us, non-severe intrathoracic or pulmonary TB is any child who has smear or culture positive, they have, it automatically shifts onto the severe form of pulmonary tuberculosis. So non-severe is when the smear and culture, they are negative. It may be that the NAT comes out positive. So NAT may be positive, but smear and culture, they have to be negative. And the disease to be confined to less than one lobe of the lung with no cavities and uncomplicated pleural effusion. If there is an isolated mediastinal lymph node, it should not be causing any obstruction and there should not be any miliary TB. And for us, for children, extrapulmonary is only peripheral lymph node. And this is different from adults. For adults, all forms of extrapulmonary TB, except CNS, osteoarticular, miliary tuberculosis for pulmonary, they are considered, or disseminated TB, they are only taken as severe. But for children, all extrapulmonary involvement, be it GIT, be it genitourinary, be it any other site, except peripheral lymph node, they are taken as severe extrapulmonary TB. And although the WHO has recommended, use of bedaquiline and delaminate for all ages, we under the program, we are giving bedaquiline to children more than 5 years and 15 kg, delaminate to all ages, but the weight should be more than 10 kg. So for us, if the child's weight is less than, if the child is less than 5 years, then the drugs to be used in case of bedaquiline as replacement of bedaquiline is, you can use delaminate if you are using the longer regimen, if the weight of the child is more than 10 kg. And for shorter MDR TB regimens, we have to give amikacin only, because delaminate is not to be used for shorter MDR TB regimens. So this is what the regimens are. I've already discussed. So with this, I would like to end my talk over here and give you a big thank you for your patient hearing.
Thank you, ma'am. Thank you for discussing some wonderful cases. Now I invite Dr. Susan Mane, our esteemed DB member, IAP NRC, Associate Professor JJ Hospital, and member National Technical Expert Group NTEP, to initiate the discussion. Dr. Susan, please.
Good evening, everybody. I hope I am audible.
Yes, sir.
Yeah. So we had these two wonderful sessions today, and we would not have had better speakers than Nicole and Sangeeta ma'am. So there are
Madam, you
certain
can stop
questions one
sharing.
by one. So first is, ma'am, any order of preference among the group C drugs to be taken to make the 6-drug regimen?
Yeah. This order of preference is different from WHO. WHO says that the first drug to be given is ethambutol, followed by pyrazinamide, and then delaminate. But for us, we have our own, as I discussed, regarding, we have our own peculiar problems. So for us, remember, I have made a mnemonic, that is DAYS PEC. DAYS, that is delaminate, amikacin, pyrazinamide, ethinomide. E is for ethinomide, P is for PAS, E is for ethambutol, and last is carbapenem. For WHO, carbapenems, they are higher up on the ladder because, carbapenems, they are really efficacious drugs. But then they require 6 months of picoline, which is a problem for our children, and it's a very expensive drug. I mean, the daily cost comes out to be about 2,000 rupees, depending upon the weight of the child. So it's not feasible for us to, that is I reserve, they are wonderful drugs. And carbapenem, rather than imipenem, which is used for adults, for children, meropenem is better. And we use meropenem, except for the problem, only for those children who have total drug resistance. Like in my institute, we even encounter those children who have bedaquiline resistance, and then there is not much available, much left, like total drug resistance. In these cases, luckily carbapenems, because of the cost and their parenteral administration with the PIC line, that is the reason still the resistance is not there. So but for us, we have kept carbapenems right at the bottom. It's not that they are not efficacious. They are one of the best drugs. I think WHO also, WHO list has them at the nearly at the third or the fourth position. But as I discussed, for us, we have our own issues. So remember days pack.
So how do we treat a sputum negative TB who has interrupted the regimen?
So, sputum negative who has interrupted the treatment, most important is you have to send the specimens. As I said in the beginning, you have to examine the child right from the beginning, whether it was sputum negative in the beginning also. In that case, then always keep in mind whether it was tuberculosis or it is something else. It could be non-TB. But if it was confirmed initially and now it is sputum negative, and the child has interrupted treatment, the child needs a thorough clinical examination. Simple things like cervical lymph nodes, then easily accessible sites, because these are easily accessible sites. If you cannot get a specimen, if this cervical lymph node is enlarged, you may pick up the organism from that rather than GIT involvement. If there is GIT involvement, always examine the cervical lymph nodes, because they may be enlarged and it's a easily accessible specimen. So, but always try to fish out the organism. Then I said, rule out HIV, diabetes, and family history. Family history is very important. If you have a family history, then there are chances that this sputum negative child, you know, if it is, you feel that it is tuberculosis, then and the child is showing signs of clinical and radiological deterioration, but the compliance was good, then in that case, all the records of the child have to be reviewed by a DRTB committee,
So another
because
one
it
is
could be probable MDR. But the
another,
call to start MDR TB treatment should not be taken in a haste. That is most important, because these drugs, the regimens, they are long regimens, and the drugs also they need monitoring, like bedaquiline, delamanid, clofazimine, and fluoroquinolones. You need to do ECGs, and then linezolid has its own myelosuppression in the initial 4 weeks. But more important than that, which I am observing, is the peripheral neuropathy, which emerges with linezolid.
another one question, ma'am, is when do we suspect MSMD in a TB case?
You know, I mean, this is, we have had lot of discussions regarding MSMD. This is a concept which is really emerged, that immunodeficiency. Where always examine the child as a whole. MSMD should always be kept in mind when your child is not improving, and we are in a fix. Always this should be kept at back of mind. I think in my um, uh, the one which I showed of poor response, I should also be adding MSMD. So, but the investigations remain the same. We should examine the child as a whole, the clinical, radiological examination, and obviously try to find the organism. And also, but in such children, always keep, surety about the compliance also.
Okay, so because of a lack of time, we will take one last question, which is very interesting. Why can't we use syrups for TB treatment, and or are they available or not available?
The syrups, the problem with syrups is we don't need syrups now. We have FDCs and they are dispersible. We have pediatric FTCs, a single tablet up to a weight of 24 kg. You don't need to put any pill burden on the child. So you in a single tablet you have 75 milligram of rifampicin, 50 milligram of INH, and 150 milligram of pyrazinamide. And the beauty of these dispersible tablets are that over here there is stratified absorption. That is, pyrazinamide and INH, they are absorbed immediately, in the duodenum or the upper part of the small intestine, while rifampicin, it prefers an alkaline medium and it will reach up to the terminal ileum, so it is absorbed better, So these drugs, uh, uh, formulated with the help of international organizations, they have a higher and a better bioavailability. Syrups, the other problem is, obviously ethambutol we cannot combine because ethambutol is hygroscopic. So dispersible ethambutol cannot be combined with RSZ. Ethambutol is available as a separate 100 milligram tablet. Now coming on to the syrup, there is always a problem of, breaking of tablets. Then the dose to be given with the syrup, because the size of the spoon may be different for different, and there is always a chance of breakage of the bottles. So we do not prefer the syrups when we have dispersible tablets.
And some of them, madam, I think have shelf life problems.
Exactly.
Yeah.
Shelf life is better for this RSZ, the pediatric formulation which is available under the program.
Madam, one question. In your first case, in which there was a failing regimen on after one month in DSTB, the dose of rifampicin started was 10 milligram per kg per day, where the range the band is 10 to 20. So, is it routine that we start at rifampicin at 10 milligram per kg
Sir, yes, this is, when the child, when the weight of the child, normal, the pediatric doses are that rifampicin has to be given in the dose of 12 to 18 milligram, that is 15 milligram per kilogram, INH 10 milligram per kilogram. But when the weight of the child is more than 39 kg, then we give the adult dosages. That is rifampicin average 10 milligram, INH 5 milligram. So this is not me who is speaking. All these are the guidelines, This is NTP guidelines, even the WHO recommendations.
Thank you.
Thank you, madam, for that wonderful session. And we are very pleased to have you and also Nicole. And I think it was a great show today. I'll hand over to Narayan sir for the final comment.
Thank you. Thank you. It was great having Dr. Nicole and Dr. Sangeeta Sharma, and wonderful discussion about the latest researchers and very interesting case discussions. Thank you all the delegates for joining in this observance of National TB Day and the program from IAP NRC, all my esteemed EB colleagues, and our incoming chairman sir also is here, Dr. Jayan Joshi sir. Thank you all. Thank you.
And at the end, I'd like to thank Dr. Sushant Mane for his effort to make this thing possible. Thank you, Dr. Sushant, very much.
Sir, I
Thank
would
you.
like to thank each one of you because when I started my presentation, I thought I was getting late. So I did not thank you. I want to thank the uh, National IAP Respiratory chapter for giving me this opportunity to come and share some of, day-to-day problems which we face in our clinical practice. And I'm sure, the cases which I got, a majority of you must have also seen such type of cases.
Thank you, madam.
Thank you so
Ma'am,
much.
sorry, ma'am, you didn't give us a chance to introduce you and your wonderful profile. It was not late known to all our esteemed delegates and EV colleagues.
Oh,
Thank you.
thank you, sir. Thank you.
Thank you, madam. Good night.
Thank you. Sir. Thank you.
Thank
Good
you.
night.
Good night.
Good night.
Thank you.
Thank you, sir.